Thank you guys all for joining. Um, if you're okay with turning on your video, we'd love to see your beautiful faces. This is the last presentation for our sort of implementation science series for our EHE hub here in Tennessee. And we have Dr. Woodward, who is here to give a presentation on equity and implementation science. So Dr. Woodward is a clinical health psychologist. She uses implementation science and practice, community engaged research, and mixed methods to improve equitable health care delivery for groups experiencing disparities. She's a formal fellow of the IRI, which I am as well, and the NIH Health Disparities Research Institute. She was a career development awardee, clinician and researcher through the VA administration, or the Veterans Health Administration, and a faculty member at the University of Arkansas for medical sciences in Little Rock, Arkansas. She is here to present her work. At the end of the session, feel free to ask questions throughout. You can just put them in the chat and we will pass them on to her. And if you have specific questions about your research, please stay on at the end of the session. And Dr. Woodward has been good enough to stay on for a little while and have some one-on-one chats. So thank you so much.
Thank you. Hi, everybody. Thanks for having me here. How is my sound, Carolyn? I can see you. We're good.
It's
Okay.
great. Yeah,
Okay.
perfect.
Great. That's great because I've got my like little Britney Spears mic that my granddad got me. Um, okay. Well, you all are coming from a lot of different places, and so I just want to give us a moment to kind of get present with what we're doing here now because life is busy. You're bustling, but you clearly thought this was important enough to come here for some reason, and I want to make sure that you get what you need. So first, let's go ahead and just do a quick mindful breathing exercise to get present. Okay. You're with the psychologist right now, so buckle up for that. All right. So go ahead and finish up a text, put your phone down, try to minimize your work on your screen, and you can close your eyes if you like. I am going to. If that's not comfortable, just kind of like look at something neutral. Maybe not the screen, but like a desk or a wall. Or close your eyes 8/10 of the way where you can kind of just see out the bottom. And just as you're sitting here, notice where your feet or legs might be touching a chair or couch or bed. And noticing where your back and arms are coming into contact with that seat. Simply noticing your body here in this moment without judgment. And as you breathe in, paying attention to where you feel this most intensely in your body. It might be your nose, back of the throat, your stomach, and saying to yourself as you're inhaling, some kind of word to acknowledge that, like inhaling or breathing in. And the same as you breathe out. Naming it and noticing it, breathing in and breathing out without trying to change your breath. One more cycle of breath. Go ahead and just kind of reground your feet and your legs and your seat, fluttering your eyes open if they were closed, and just kind of coming back to this space where you are now. Thank you for doing that with me. Okay. Well, I am so thrilled to be here, and thank you so much to all the folks at Vanderbilt University for making this happen. I am located in Little Rock, Arkansas, about 5.5 hours away from Nashville, and am really excited to talk to you today about one particular aspect within how can implementation efforts reduce healthcare disparities and promote health equity in my work. that's what all of my work is centered around. But one particular advancement that my team and I have made and are continuing to grow is the use of the health equity implementation framework. So what we'll do is I'll show you in visual and explain the framework with its domains and some measurement suggestions there, and then show you an applied example of it. And then we'll pause and kind of talk about it more and see what's on your mind. And that'll be about 15 minutes. And then people inevitably have some common things they tend to ask. And in that case, I've got some more visuals to kind of show you to explain stuff, but we'll just see where you want to go. Okay. So let me share this because I'm doing a whole new thing for me, like presenting in this online format. Here we go. All right. It's loading. The title of my presentation is, if you don't look for it, you probably will not find it. Determining barriers to equitable implementation in healthcare settings. Oh my goodness, my text is all wild in this online version. Okay, well, you know my name. And then I also want to give credit to someone whose name is really messed up on there, and that's Dr. Sonia Singh. Her former name, or her formal name, is Rajinder Sonia Singh, and she works with me at the VA Center for Mental Health Care and Outcomes Research in Little Rock and the University of Arkansas for Medical Sciences. And she and I have advanced a lot of this work together. Okay, the title of this talk is essentially to allude to the sense that, the common sense fact, if you are trying to assess a problem with implementation in any setting, I have done this most in healthcare settings, but it could be, if you might be working in child welfare setting, criminal justice setting, you might be working in schools, and this can also work well there. The sense, though, is if you are not building in some purposeful assessments for disparity issues and social injustices, you probably will not detect those problems. And thus, when you go to design your strategies and actually try to implement what you're trying to implement, you are likely to be missing a huge uh, contributor to its success or its failure. Okay, a few acknowledgments and a disclaimer are listed here, including the VA Office of Health Equity, my Career Development Award, and in Little Rock, our Implementation Science for Health Equity Lab. I'm also a consultant for ViV Healthcare Incorporated and will not be promoting anything related to that today, but did want to disclaim that. And also share that the views in my presentation are solely mine, not representative of the US government. Okay, let's just make sure we're on the same page in terms of health disparities, health equity. There are health differences that are differences like in a health outcome between two groups that might be based on a specific characteristic like height. There might be problems, a certain health problem that affects tall people versus short people more, but a health disparity has another level to it. So not all health differences are disparities. Health disparities are concerned with social justice. So that's when there's a difference in health outcome, or there's a difference in the receipt of that service, or perhaps the quality of care when it's delivered. And the group that's struggling more is experiencing a lot of oppression societally, has experienced a lot of marginalization, and the reason they're doing worse is not due to their choice, and it's seen as an unfair inequality. And so health equity is a principle underlying a commitment to reduce those disparities, and by addressing many of its determinants, including social determinants of health. So here's a visual. You've got equality on the top and equity on the bottom. So equality is, there's four people who each have a bicycle, and they all have the same bicycle. And you can see there's a person using a wheelchair who can't even get on, and a very large person who's riding it but very uncomfortable, and a very short person that is kind of riding it but cannot reach the pedals, and so likely is not getting the most use out of that bicycle. And you can think about implementation strategies like this. It's probably not equitable to give everyone the same implementation strategy, although it's much easier. And one solution to that is tailoring implementation strategies. Because you see at the bottom, when we have equity, each person has a bicycle that's more fit for them. So the person who uses a wheelchair has a hand trike and they can actually participate. The person who's very small has a very small bicycle and they can actually get the full range of motion and hopefully the benefits of riding a bike. And so this is a visual to consider how strategies might be tailored in implementation science or practice to best fit the populations. And again, one way to do that is through tailoring and adapting those strategies based on a very good assessment, which can go by the name of a formative evaluation or a diagnostic assessment, or identifying barriers or facilitators to the implementation gap. When you do that well and informed by equity, you're better able to then tailor to equity. So even though we're talking about giving strategies right now, the step that comes before that, a good diagnosis, a good assessment, is key to be equity informed. And so we'll talk about how implementation frameworks can apply to that today. And in the last iteration of kind of the textbook of D&I research and health, and this has a third edition that's out now, there was a quote that implementation frameworks might be modified or adapted for application. That chapter was specifically among racially and ethnically minoritized people, but also other people who experience healthcare disparities. Many lesbian, gay, bisexual, transgender folks experience disparities in their healthcare that are unjust and unfair. People who are low income have a lot less access or lower quality of healthcare or to healthcare when they receive it. And it depends on your health problem and in your health area. And so the modifying and implementation science framework is something that I led in 2016 that resulted in the health equity implementation framework for this exact reason. Just in case, to lay some background here, there's 3 types of implementation science frameworks. You have the determinant frameworks, which ask like, what are the barriers and facilitators here and why? That's like your good diagnosis. You have kind of process or planning frameworks that help you guide, how is this thing actually going to get implemented? And your thing is your service, your innovation. It could be a policy related to equitable housing to help people living with HIV. It could be HIV testing in a clinical setting, or maybe in mobile units that are deployed out in the community. It could be antiretroviral therapy for people living with HIV. So the process or planning frameworks actually guide you through how to do that. And the third type are the evaluation frameworks, which help you measure, did we succeed or fail? And the important part for a good assessment is a determinant framework. And that's what the health equity implementation framework is. There are some people that are actually starting to use it for evaluation, which I think is interesting. And they aren't advanced enough in their work, to my knowledge, for us to really have fleshed out examples to know if it's going well or poorly. But I think it's interesting. And I'm excited to see what happens. So the health equity implementation framework is a combination of many things. Primarily on the right, IPARIS, which is a really foundational implementation science determinant framework that came out of nursing literature, and the healthcare disparities framework that came out of work from the head of health systems research in VA. And then a lot of literature searching and consultation with health equity experts and implementation experts, including the people who authored these existing frameworks. And I went and used a lot of seminal texts in health disparities research to also find existing frameworks in health disparities research and bring some of those factors in to IPARIS, which is a determinants framework. And so I'm going to map out the health equity implementation framework here in circles. The first one is the innovation. And this, remember, is the thing you're trying to implement. ART, HIV testing, gender-based programming, prevention of intimate partner violence. And so there are certain factors about that that make it more or less likely something will be implemented, like how much advantage it has over an existing practice, how much it fits. And then there are the recipients. Now, recipients in this framework does not just mean the end user receiving the service, like a patient in a healthcare setting. It means all of the people who are receiving the service, but who are also receiving implementation strategies, like in healthcare, clinical providers, other recipients such as front desk clerks, technicians. And there are many factors within each of those groups that are important to attend to. I'm not listing all of them for any circle here just due to space, but they are in our published papers on this topic. And a star signifies one element where I adapted iParis to incorporate a health equity relevant domain. And so the first one is that each recipient has culturally relevant factors that inform how they see the world and what they're more or less likely to do. This could be things, based on their lived experience, like their viewpoints on another group of people, any bias that they have. It could be their beliefs for their own healing and traditions from their family about, you know, what will be helpful to help this ailment. And then all of these people come together in a clinical encounter in a healthcare setting. It might be a community encounter or a teaching moment in a school, but basically that moment when the innovation could be offered to the end user by one of the other deliverers or the providers. And then that clinical encounter could be accepted or denied, or delivered half-heartedly or well. So what happens in that clinical encounter is also an important element from health disparities research that has been missing a lot in implementation science, because everybody here, I'm hoping you're getting healthcare somewhere. And if you just think about your lived experience, what happens in the room when you go to get your healthcare really can make a big difference on uptake of whether you're going to follow through with something or whether something's even offered to you. And there can be limited communication. There can be, looking at a computer and the whole time and not talking to you. There can be offensive jokes that are said to you, even in that setting. And so what happens in that clinical encounter is important to understand. And so it has a star. It's a unique health equity domain. And all those people and innovations are nested in a context in the system. In healthcare, you've got the inner local level, like it might be that clinical service, and they're within an organizational level, perhaps a department, and that's further nested in a whole healthcare system. And you can adapt this, for, let's say, an early childhood education setting. Your inner levels may be the classroom, the organizational level might be the school, and the system might be the region of schools that are connected in a district. And also, I don't have it listed on here, but how much experience that context has with addressing equity problems or quality improvement will impact implementation as well, good or bad. And all of those people and places are nested within society. It's got a star, the societal context. So these are really where those social determinants of health and their interlinking structures come into play. So they might not be directly showing up, in a clinical encounter, but the societal contexts are certainly impacting what's happening for patients, providers, other recipients along the way, and whether they might adopt a practice, whether they might follow through with it or deliver it to more people. So some of those factors are economies on the right. That's how goods are exchanged in healthcare. That's who's paying, insurers or private pay, and what they might expect or demand, or how that influences care. Physical structures. So you might think of this like the built environment if you're from the public health world. So these are, the actual physical ways and experiences and navigation that people have to go from wherever they are to get your innovation. And so you can imagine areas with really difficult topography, where it's hard to travel, or highly rural areas where you're going 4 hours one way for an appointment. Um, Even once you're in a clinic, are there confidential spaces to do something that maybe is kind of stigmatized there? Those physical structure elements play in. And then also socio-political forces on the left. These are social norms, the way things are viewed in a certain culture or society. These are political forces, either policies, at a big level, or big P policy, or laws. For example, when I was working on helping implement more HIV testing um, in Jamaica, there's not a lot of um, HIV acquisition through injection drug use. It's primarily through sex. And um, same sex behavior is criminalized in Jamaica, it's against the law. And so there's a very, that has a, that affected all the circles on the inside very differently. And we needed different strategies because of that to even roll out HIV testing. So when you get all these things together in your good assessment, you can assess barriers and facilitators within those domains, and then you need to do something about it. So this framework proposes that you use facilitation, or could be other implementation strategies, and that theoretically you would get more implementation success, but also improvements in health equity. Now, those things have some evidence behind them, those pathways, and there's also still a lot to be tested there. So good. In some of my work, we're starting to test some components of this framework theoretically to see if they actually pan out. And I would love it if you do that in your work too, because there's a lot of work to be done there. So the main take home point is this: assess 3 health equity determinants in any implementation effort. And those 3 determinants are the culturally relevant factors of the people, the recipients, the clinical encounter, that moment when the innovation can be offered, and the societal context. And there's lots of ways you could do this. Our lab published a paper listed here, a more practical guide to incorporating health equity domains into any implementation framework. And in fact, I'm going to post that link in the chat here for you. There we go. Okay. Oopsie. So here is a brief overview, but if you go to the paper I just put in the link in the chat, the more practical guide, table 1 lists all the domains, and with an comprehensive list of kind of each of the constructs that can be measured within them. And then it lists some definitions, and then we listed an example or two of how that has played out in some implementation effort that's published. And then we gave some sample measures and methods. They are not exhaustive. So if you think of a great way, or you are already trained to assess that domain in a way that is really your skill set, then go for it and write about it, and make it explicit, and let me know, because I'd love to know, advancements people are making. So at sample measures and methods for the societal context might be looking at insurance claims data or linking it to some data set, observing the physical structure. So that could be the old windshield survey or walking survey from public health fields. Document review of organizational policies. So actually looking at what are the policies, the organizational charts, the patient handbook, the patient bill of rights, to kind of see what some of the cultural elements are, the requirements are. Or even if you're in the US, state level racism index, if you're studying a disparity problem that is predominantly there due to racism and racial discrimination. There's a great toolkit for many social determinants of health in the PHENEX toolkit that's hyperlinked here, that the National Institute of Minority and Health Disparities has assembled. It's not data, but it's measures, and here's some social determinants that science basically shows predict health, and here's ways you can measure it. The second determinant, to remind you, that second domain is culturally relevant factors. And so some sample measures and methods are, actually, if you're drilling down into chart reviews, to calculate like a demographic match between patient and providers, or seeing, some of using natural language processing to examine, how providers are writing about patients in the healthcare setting, for example, administering a medical mistrust survey, assessing the health literacy of the people that you're wanting to be end users of something, or individual interviews to assess something more about cultural elements or preferences for care and it could be among the people delivering the care or the people receiving it. And the final encounter is the clinical encounter. Again, that moment when people come together. I have not I have assessed this informally in my facilitation work, but I have not yet formally measured this in any of my work, but other people have. And here are some of the methods they use. You can actually audio record those encounters and use a type of like conversational analysis to process how that conversation goes, whether it's sparse speech, whether it's extremely long words. You could videotape those encounters if people are, a sample of them to see how people are going. I see how people are doing and if they're, adhering to fidelity. And you could use that to measure multiple outcomes, including aspects of that might predict health equity. And you could actually interview those people or chart review documentation. So those are just some ideas for you. Now, there is an example that is in our published work that we used with uptake of hepatitis C treatment among Black and African American veterans in the VA system. Just to make sure we have enough time to tailor this to you, I can share that in a moment if you'd like. But I first just want to stop, share, and see what things are you wondering in terms of where you are in the world, your work, what you're interested in. As you hear me talk, what is still feeling like a stuck point or something that's really resonating that you're wanting to share or that you're wanting to talk about and ask? Feel free to unmute or put in the chat, whatever you're comfortable with.
I'll just say before, just as other people are getting their thoughts together, that in one of my implementation science classes, people talk a lot about that they work within sort of Vanderbilt Medical Center or medical
Mm,
system.
mhm.
And they say whatever they do to develop strategies here, there's a certain group of people who will never come to receive care here, whether we don't take their insurance or they don't feel like they have access to it. So the strategies they feel like aren't going to get to like the meat of the problem. And they're like, what do I do? So if you want to maybe
Yeah.
address that.
I mean, I hope we're all addressing that. My thoughts on that are, I think that's very insightful. And I think that reflects, people that are doing the work, like the people in your classes who are observant about, you know, where maybe the incidence and prevalence is highest among the people in their disease state, like if it's HIV, for example, and then looking at who's actually receiving care. By the way, that's a great way to do some initial equity lens stuff in your work is like when you assess reach, like assessing the demographics of the people you're reaching and seeing, does this match with the people that actually are disproportionately affected? So I think I'm already heartened by that they've gotten to that place. They're like, yeah, we're still missing some people here. And then the strategies might need to extend, probably will need to extend then outside the healthcare system, which is some of the work I'm doing now for that exact same reason. And as a person who's like a healthcare system implementer, it's uncomfortable, because I'm trying to implement in these other settings outside the system. And I'm finding it most helpful to use community-based participatory methods to do that. So that's my first thought is like, well, then take it to the people, take it where you think people are going to be. And, it depends on your disease state area, but there's increasing funding for that too. What other thoughts or questions are people having so far?
Hey, Eva, I'm trying to remember. I used your framework in a proposal recently, and
Okay.
I was trying to like dig through and find which one it was. But I'm trying to figure out how to apply it to like community, non-clinical settings.
Okay.
I don't know if there's an equivalent to the patient-provider interaction.
I mean,
Maybe-
some,
Oh,
I guess, I mean, the time and place, and you know, you'll have to call it something else, or you don't have to, but you can. The time and place when someone is coming to receive the innovation you want them to,
mhm.
or they're not coming to receive it. They're coming to do something else, but you want them to be offered that. And they might say yes or no. You know, what would you call that in the settings you're working in?
I think that helps. I think sometimes there is that interaction. Other times I think we're trying to like change the environment, like put in a walking path to help people not even have to
Mm,
think about it and walk
uh,
or bike
uh,
for active transportation.
okay.
In some cases, maybe there's not, but in some,
Yeah.
maybe there's
Yeah.
some type of interaction that makes people feel more or less comfortable
Mhm,
in those
mhm,
spaces.
mhm. You know what might be, I'm sorry, do you want a thought on this or no?
Well, I don't want to totally tangent,
Okay.
but
Okay.
happy to talk about it as much as you want.
Okay, I'll give one thought because
Okay.
I bet there's other people in the room implementing in community settings or having an innovation that's like a mass offering kind of, you know, like a walking path is like theoretically anybody could get on there. You know, and so when you're doing really population health level stuff like that, I wonder if, first of all, I would just say, is there value in you actually assessing the moment they encounter that opportunity to get on the walking path or not? Because if there's not going to be value, then don't assess it or measure it. But it would
Yeah.
be interesting if you were finding it underused to um to kind of like do some in real time data collection, you know, with people who might drive past it, like traffic patterns, or and kind of post yourself up there for these like community level data collection measures, like very
Mhm.
brief interviews of like, hey, have you heard about this walking path? Oh yeah, I see it on so and so. Okay, and have you used it? Okay, why or why not? What's, you know, and suddenly you're now getting some information about their clinical encounter, or
Mhm.
the same. You could actually just have some data collection happen on the walking path and
Yeah.
ask people then, the people who are using it, maybe it's like not totally meeting their needs, or they're less inclined, or they don't come as much, and again, you might discover things that are more environmental, but you might discover something about the walking path itself that needs
Mhm.
to be adjusted. That's a thought.
Yeah. Thank you.
Yeah. Other questions or things people are kind of rolling around in their minds related to health equity implementation framework or relevant things? Remember, I'm a psychologist. I could just sit here and quiet. I won't. That's not a threat. That's not a threat. Just like to give you space. Just like to give you space. Okay. Okay. Well, put it in the chat, or, you know, loop around to it. Let me show you. Let me show you a brief example, and then I want to show you another example of how a very common question I get is, well, what if I'm using another determinants framework I like already? Like it wouldn't be IPARIS, but the theoretical domains framework, CFIR, the consolidated framework for, you know, the most popularly used. And I want to have a health equity lens in that. So I've got some work on that that I want to share with you. Okay, let me get back to sharing my screens because visuals are so helpful. Okay, so this was an example of when we did, this was the first pilot of the health equity implementation framework. This is what's published in our main um, 2019 paper. And so I'm not going to go into super depth because it's there, it's published. These essentially, what was happening in the VA at that time was for those who are not familiar, there was a new treatment rolled out for hepatitis C virus that had, thinking about the innovation circle and relative advantage, it had huge relative advantage to treating hepatitis C. It cured up to 92% of the cases, and people took a pill for 3 months every day. And that, what they got before was interferon, which had a lot of side effects and was marginally effective and rarely worked. And so tons of relative advantage. And in the VA system, Congress allotted special funding to make it free for veterans, because outside the VA system, it was $80,000. And so in the VA system, it's like, great, this thing is so much better than what's out there already, and you can get it no cost. And yet, we're not seeing as high of uptake as we'd like. And then even further, when we look at the populations by race that are disproportionately affected by HIV, this is true for in the general U.S. population, that Black adults are more likely to be living with, I'm sorry, not HIV, hepatitis C. Well, also true for HIV, but Black adults are more likely to be living with hepatitis C than white adults. And yet, in the VA, white veterans were getting were more likely to get the new treatment than the Black veterans. And so the VA was very concerned about that and said, okay, we need to put all hands on deck. And so many different research teams across the country started to investigate why that was, for a very good assessment to design a good plan to improve its implementation. And my team led the element where we assessed basically the end user perspective. So we talked to Black veterans who are living with hepatitis C in the US South, and did qualitative interviews with them. And the short version is that most of them were underemployed, and a majority had heard about hepatitis C treatment before, but only a few of them had actually started it or completed it. And so this was in the fall of 2016. We did phone interviews with them, and we asked them about HCV treatment, hepatitis C virus. And then we asked barriers and facilitators about all of those levels in the health equity implementation framework. And specifically mentioned, like, we want to understand if there have been instances or anything about racial discrimination you've experienced. And so here are the barriers we found. At the innovation level, the people who did receive the medicine, they wanted a medication reminder system. At the end user level, some people didn't even know what the symptoms were, even though they were diagnosed. So there was very low, health knowledge about this condition. And they either reported no trust in their clinical providers or very submissive trust. And what we defined that as was, trust that's kind of consistent with a cultural element of, at least in US society and other societies as well, and certainly amongst more generations, some generations more than others, which was, I just do anything my doctor tells me. So if they didn't tell me, that I needed this, then I must not need it. At the provider level, the patients perceived that there was racial bias, that they were experiencing racial discrimination from their providers, and that their providers didn't have enough knowledge about the treatment either when they had asked questions about it. At the clinical encounter, it was negative for them when providers did not offer the treatment. And then if we were explaining this in the research study, like, this is actually out there and it's available to you, really upset, which is understandable. And that's a reasonable response. Or when some people had reported, oh yeah, my doctor talked to me about that, but they didn't really talk about the rationale for the decision. Or, we talked about me having hep C, so they ordered the test, but then I got that I was positive, and then there was no follow-up. So things happened in the clinical encounter that left a bad taste in their mouth and didn't get them to the point of getting treatment. At the organizational level, they reported a lack of follow-up after testing positive, and that there was not enough hepatitis C virus treatment at certain local facilities, because we were talking to people in rural and urban areas, and people more at the rural clinics didn't have enough treatment there. They were like, I got to drive all the way. And even though VA can mail medicine and all this, they needed to at least see a provider before and after for labs. And that was a huge barrier. Physical structures were in those rural areas major transportation barriers, either drive time or people who couldn't drive for whatever reason and say, oh yeah, there's like, the bus will come pick you. Like there's a volunteer group that helps veterans get to their appointments, but like it's once at 5 a.m. And if my appointment's like at 3, this is a really big, this is difficult for me. From the outer healthcare system, they reported testimonials from other Black peers about racial discrimination that they had experienced at VA, even if it was 30 years ago or, before the civil rights movement. And it still was in their hearts, it was still in their minds that they were quite leery then about accessing care there. And also, just in society, they reported that there just weren't enough materials about hepatitis C going around, especially in the rural areas, especially with a high stigma. So the only thing that they felt like they or people knew about it was, oh, you must have gotten it from using drugs. What happened? And so that was highly stigmatized. We also identified barriers, smiley face. An economic facilitator of that was that the treatment was free in the VA. The regimen that the medicine required and its cost was acceptable. And when asked about like, would you like to try this before you totally committed to it? They're like, no way. If this could cure me in 3 months, like just give it to me, So that, again, that helped us conserve resources in the implementation planning, something we thought they might want. They're like, no, no big deal. So again, if you don't look for it, you might not find it and you might waste some money and time. Among the patient level, they really hoped there was no racial discrimination from their providers or MVA. They were optimistic about the treatment and they wanted more hepatitis C virus education. And some of them had positive trust in their providers, just depending on the relationship. They perceived from the providers that they said, some people really do want to help me there. And some people I feel like are not super racist there. And I like those people and they make me want to come back. At the clinical encounter, they described positive in clinical encounters when the providers explained treatment, the side effects, next steps, and asked questions. And so actually one thing we did with the data here based on when we got to the implementation planning step was all the data we collected about the clinical encounter, we ended up making a vignette about a negative clinical encounter related to hepatitis C treatment and a positive one. And informed by their data, like kind of a mashup of multiple viewpoints, but was still consistent with what people were describing as principles of a negative appointment and principles of a positive appointment. And we ended up using those positive and negative vignettes in then some later like provider training, for example. So another way in which this good assessment and the data you collect can be used for actual action in your implementation strategy step. And that in the healthcare system, they said, I know that the VA uses a lot of best medicine, a lot of best practice, and they want to help veterans. And they really offset some of the stigma around hepatitis C because they're so confidential. They're so locked down. I know they're not going to tell my business. And in fact, they had heard positive testimonials from other people in their life about the hepatitis C and they were more likely to go seek it out. And some people had seen some written materials like in their clinics circulating, and it made them more likely to want to go. So this other example that I'm about to show you, well, let me pause. I don't know how to go back on this thing. Oh, I'm just going forward. I'm going to stop this bloodbath. The other, the Hep C example, then what happened is like then they combined it with the office in charge of this combined it with assessments of other levels, like at the clinician and nurse level and then really at the organizational level, and they put it all together and made this very comprehensive implementation plan that then they executed. And then wonderfully, most veterans with hepatitis C, regardless of race, have gotten treated, I think, at this moment in time, and the racial disparities went away. And at this moment in time, I think only like 30,000 veterans living with hepatitis C virus that are getting healthcare there are untreated. And they're finding that those folks Now that's going to require different implementation. Back to Carolyn's point, these are finding mostly these are veterans that are unhoused and living on the streets or living in shelters or have comorbid substance use and mental health, severe mental health issues. And so they're having to now adapt and figure that out. They're having to go into the community rather than expect people to come to them. Okay, so let's move to the question of I'm using my current framework. Can I do some health equity stuff in it? The answer is yes. The simple answer is add the 3 health equity domains that I just reviewed now and that are published in our 2021 paper on more practical guidance, the one in the chat. Add those to your current framework. So here's an example that I'm going to skim to make sure we have time to talk, that I helped design this study, but all of the work was led and then conducted by my colleague, Dr. Sonia Singh, in Little Rock at the VA Center for Mental Health Care and Outcomes Research. So she assesses and helps promote and implement a policy, 2 policies actually. So the innovation she's wanting to be taken up more is our policy, basically behaviors consistent with the policy. And those policies are relevant to gender affirming care for trans folks in the VA. So veterans that are transgender or non-binary. And she did an initial assessment of implementation barriers and used CFR, the Consolidated Framework for Implementation Research, which is very popular. This was at the time when it was CFR 1.0. Now there's CFR 2.0, which, by the way, and CFR 2.0 has a little more health equity bent to it, but even it doesn't go as deep as the health equity implementation framework. And Laura Damshort and I've talked about this, and we've presented on it together. So that's a known critique that they know. And we both have agreed that one great solution is to take CFR 2.0 and add those 3 health equity domains that my team and I have identified into it. And that's exactly what Dr. Singh did here. So these were kind of the 5 basic domains you see on the screen to assess. And then again, she added, and I helped her design this, those 3 health equity domains. And so when it came to just the 3 health equity domains, she was doing qualitative interviews with veterans who identified as lesbian, gay, bisexual, queer, transgender. Oh, I misspoke earlier. Or I didn't tell the whole story. She's working on the implementation of 2 policies in the VA. One is for gender affirming care, and one is for sexual identity affirming care for queer folks. So she did interviews among veterans who identified with as part of that community, and asked them, do you have a general sense of the last provider you saw and their beliefs related to LGBT veterans? Each VA hospital also has a care coordinator that's meant to help coordinate care and programming for LGBT veterans and the clinicians who work there. And so she asked them, do you have a general sense of providers' beliefs related to LGBT veterans or non-providers, like people like technicians or scheduling clerks? And then she asked providers, is there anything about LGBT veterans, from your area that can sometimes create barriers to delivering appropriate or high quality care? And the idea was to get into some of these culturally relevant factors that these different groups either believed or perceived around them that other people did. She assessed the clinical encounter by asking the veteran, are there any providers or staff you interact with who you feel like are very affirming to your identity as, a lesbian or a trans man? And what exactly do they do that make you feel this way? She asked the care coordinators, have providers at your hospital shared any concerns with you related to providing LGBT affirming care? So to kind of get at, as they're trying to have that encounter, they're trying to offer something and let people take it up, what are they running into? And she asked the provider, have you ever felt unsure or confused during a clinical encounter with a patient who identifies as such? So these are ways to start to get at some of what might be happening in that clinical encounter. And finally, in the societal context, she asked all three of them one question, which was, can you think of any factors outside of our healthcare system that might impact the care you receive as a veteran who identifies as, LGBTQ? Or she asked providers or coordinators, like, it might impact the care you offer to LGBTQ veterans. So let me pause here because I just wanted to show you how she measured that. And sure enough, she ended up with some really excellent results that she would not have found otherwise, that were more thorough and more deep. And it's a really helpful way to work in that health equity focus in your frameworks for diagnostic assessment. So let's pause here. Thoughts on that? Questions, something, when you think about your work that's coming up that is really, burning for you that you want to talk about?
Hi, Dr. Woodward. Thank you for this information. It's been really helpful. We're planning to apply the Health Equity Implementation Framework to an initiative that we're planning right now that will assess and address social drivers of health in primary care clinics at Vanderbilt. And so right now we're doing focus groups with different stakeholder groups like patients and clinicians and staff to understand how best to approach the initiative.
Okay.
And the health equity implementation framework just seemed very appropriate given health
Yeah.
equity lens and the types of factors that we're considering assessing. And so I just had a question, and I think this applies to a lot of different frameworks where we have the domains that the framework covers that we would like to include in the focus group in terms of the questions that we're asking, but maybe not all are relevant or appropriate. And then in the reverse, there's questions that we would like to ask in the focus group that aren't represented anywhere in a current domain within the framework. So I know there's like flexibility, and like you're even suggesting, like, if you didn't use the health equity implementation framework, you have another one, just add these domains to it, and that's okay. So I think there is like that flexibility, but I just wanted to see if you had thoughts to like on how to navigate that when it's like some domains are clearly present and we will capture them, and there's going to be a clear mapping of like with the questions that we'll assess and how they relate to the framework, but there's other like deviations that will likely occur too, and like, is that okay, or like how you've handled that in the past?
Oh, it's such a common thing you're up against, and where I thought you were going that you didn't was, and also we don't feel like we have the time or can ask about all these things.
Sure.
But
Yeah,
that's
that
there.
too.
Yeah, that's there. That's there. So let me wrap that in with this.
Great.
Because I'm sure other people are wondering, like those interviews I did for the hepatitis C stuff, like it was intense. It was intense. And I was like, whew, this was a lot of work, and I don't know. And it was a lot of time, and I'm not sure. I mean, I could do it comprehensively again. But it was a lot, and you might not have the time, energy, or it might not be the point. So I think if I zoom out, to me, it makes sense to use important evidence to make those decisions. This is just my viewpoint on this, which is, and by that I mean, it could be evidence from research, like you have data that suggest certain variables or factors are really important for this, which might be how you're coming up with like extra things. I'm not trying to minimize them by calling them extra, but
Sure.
outside of the framework, extra things. And to me, I'm like, then that's got to be in there, because each population and setting and health problem is going to have some different permutations that will make some things more relevant that might not be captured by an existing framework. And we would hate to let the framework be the rate limiting step
Sure.
of that knowledge. So I'm all about that. In terms of then what to do with those extras is either really see if you might ask around, or even shoot me an email of like, do you think this, like, is there some place where you think this might go? Because some people will do that to me, and I'm like, hey, it totally goes in here, here, and here. And they're like, oh, I didn't even think of that.
Okay.
And of course, that's just from my viewpoint, but you can
Right.
also ask around. And or you could also just say, yeah, we have this data from the health equity implementation framework and these other things. And you take that, however your analysis works out, you make sure that your code book or your template or whatever
Mhm.
accounts for all of it,
Mhm.
um, so that data is really attended to. The other question about some domains do not seem as relevant. If you, again, from an evidence informed way, you and your team think that that's true, and patients are telling you that's true, it's like, then don't explore those, and say why. We
Okay.
didn't, we assessed this and this. Out of the health equity implementation framework, we assessed these domains. We did not assess this and this because they were not repeatedly brought up as themes. There's no evidence to study this and shown that this doesn't predict it, or it's completely irrelevant to our setting.
Just justifying
Yeah,
it
to
as
me,
part of
it's like,
data.
yeah, I'm like, a framework is simply a tool. It is meant to be useful. And so if you got to take some things out or put some things in, I mean, again, but to me, that as a scientist, and even in my training as a clinician, I'm like, then make sure that decision makes sense and is formed by evidence. And by that, I realize I didn't say this. Evidence constitutes many things. It's not just like your P is less than 0.05, like for RCT evidence, could be like evidence you're getting from the patients in its primary care setting.
Sure.
Maybe you all have preliminary data that, like, actually this is really, really important. And one of the reasons we're even doing this whole thing, and we don't feel like it's currently captured by these frameworks, that's evidence.
Sure.
And so that's my thinking on it. What do you think?
That's super helpful. I really appreciate it.
Yeah.
Yeah, I think it all makes sense. And I appreciate you offering too that, like, when we get to the point of analyzing the data, if you're okay with me sending you an email and
Yes.
saying, hey, do you actually think this does fit here? Because, like, I think there is,
Yes.
like, sometimes you just kind of need that extra validation that, like,
Yes.
yeah, or maybe it's this domain, but yeah.
Or maybe you're onto something new, and it's, and I'm like, wow, when you write this up, like, again, the health equity implementation framework is new, and it's partially tested and partially not. And that's really where the field needs to go in terms of that science. So you could be advancing, this important initiative with social determinants of health. I'm guessing it's probably like screening and services. That's just a guess.
Yes.
Okay. And that's a guess because I am still clinician in primary care, and we're doing that. And you'll advance that work in the Vanderbilt system, which is such a gift. And at the same time, you might have a second piece evolving there of kind of like doing, evolving the work of this framework, which would be great. Or equity related constructs and implementation science in general, which I think is amazing.
Cool. Thank you so much.
Anytime. I'm excited. Okay, I know we're at 1.
Yeah,
You
we're at
guys
1.
roll
But
off.
if anybody would like to stay and ask any specific questions to Dr. Woodward, you're more than welcome. Otherwise, thank you so much for joining us.
Thanks, bye.
Bye,
Bye.
Thank
Laura.
you.
Bye, everybody.
Looks like we're actually good. Lindsay, do you have any questions you want to ask?
No, that was super helpful. I appreciate it. Yeah, I have to run to a different meeting, but thanks, Dr. Woodward. Dr. Woodward, I'll definitely be in touch. I'm excited about the framework. And I think it's exciting too that it's new and it's still kind of in its infancy, and we can, do different things to try to evolve it and advance it. So yeah, it's kind of like you said, there's kind of 2 different avenues that we're pursuing.
Yes. And and I don't want you to under highlight or miss that element of your work. What is the purpose of science if it's not evolving? So
Right.
you
Right.
go.
Cool. All right.
Okay.
Thanks, guys. Take care.
Bye.
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 Thank you. Thank you so much. We really appreciate it. And I know you'll be in touch with Tina after, but we really appreciate you taking the time.
Oh, absolutely. Thank you for inviting me. Hold on. I want to see that Annette is still on. Annette, do you have something on your mind?